Hello, today's web lecture is about topical sealants in trauma surgery. Our objectives: review surgical sealants for trauma patients, including those which are fibrin and thrombin based, synthetic polymers, and protein aldehyde polymers. Topical sealants are used to prevent fluid or gas leakage from an organ or vessel. There are many products available, but few large clinical studies. The FDA approves glues, sealants, and adhesives for use in patients as devices and not as drugs. There are issues in terms of what is their effectiveness, how easy they are to use, and complications that can ensue after use of these drugs. Fibrin and thrombin sealants are widely used. They come usually as a dual syringe system and can have additional factors added to the fibrin and thrombin, such as a protein or factor VIII, to improve the quality of the sealant. These frequently come as a two-part syringe, which often needs to be assembled, and then with the combination of the fibrin and the thrombin at the tip of the needle, a thrombin clot is produced. It has been claimed to be effective in patients undergoing cardiopulmonary bypass, patients during a splenectomy for trauma, avoiding incidental splenectomy in patients undergoing other procedures, during colon anastomosis, liver resection, during vascular procedures, and for skin closure. Products which are for sale in the United States, most commonly it's known as FloSeal, as sold by the Baxter Corporation. Also available is Vitagel, sold by Angiotech. In Europe there is Vitostat, which is sold by Vivolution. FloSeal is pooled human thrombin and fibrinogen. It's made from live donors. It also contains a protein and can be used as a spray or as a needle injection. It requires a special warmer and mixer, and the syringe, after being filled, has to be assembled on the back table. It typically takes 10 to 15 minutes to prepare before use and does require this special warmer mixer. It can be used as a sprayer if a spray tip is adapted, using a device which provides, say, air or nitrogen to allow spray. FloSeal traditionally took 10 to 15 minutes to set up, although new pre-filled frozen syringes can be thawed up to 48 hours before actual use if it's required more quickly. It takes about 2 hours to reach full strength. It's reabsorbed by the fibrinolytic system in about 10 to 14 days and cannot really be used for rapid or brisk bleeding. There's also some controversy about its efficacy where there are active proteases, such as around the pancreas, in proximal small bowel anastomosis, and in the urinary system. Other products use autologous fresh platelet-rich fibrin rather than donor fibrin, and this has no risk of viral infection being an autologous product. However, it does have extended preparation time, which are 6 to 7 steps to collect blood, separate the fibrin and platelets, and re-administer this. Fibrin sealants have been the most extensively studied of the sealants. There are 67 prospective studies looking at these agents. A Cochrane review looking at 7 trials to determine whether the decreased need for perioperative transfusion indicated that there was a reduced need for transfusion by 54%. 8 trials showing perioperative blood loss data, however, showed that the reduced blood loss was only 134 mLs. So these two series are difficult to reconcile, as 134 ml blood loss reduction should not lead to a significant reduction in transfusion. The Cochrane review pointed out that fibrin studies are small trials of mixed quality, 91% of which were unblinded. And the correlation between blood loss and transfusion I described is poorly correlated. Another product is FloSeal. This is also made by the Baxter Corporation. It's human thrombin with the addition of gelatin granules. This forms a hemostatic matrix and comes out of the syringe looking something like oatmeal paste. It swells slightly after application, and the maximum swelling is seen about 10 minutes after application. It also comes in 2 parts and has to be mixed. It's ready in about 5 minutes after opening, and it can be applied to brisk bleeding and does have a better hemostatic effect than FloSeal. Here's FloSeal being applied to a femoral artery injury. After the injury of the femoral artery, some pressure is applied. The FloSeal is then applied to the area of the arterotomy. And pressure is applied. After a few minutes, subsequent inspection reveals that bleeding is improved. Further application of FloSeal is made to stop any further bleeding. Other products available include synthetic polymers. These include CoSeal, made by Baxter, DuraSeal, made by Confluent. These are polyethylene glycol polymers, and they basically bind to themselves and then polymerize. They come in preloaded syringes and don't require any pre-use mixing or heating. Basically assemble the syringe and use. CoSeal has a mechanism basically of PEG, which polymerizes and chemically binds to itself to form a bond with the tissue surface, and this forms a mechanical barrier. It does also bind to prostheses material and can act as a sealant, particularly at vascular anastomoses or dural closures. It does not interact with the clotting cascade and therefore is not removed by fibrinolysis. It is resorbed more slowly than TISSEAL in about 30 days' time. Indications include vascular reconstruction for additional hemostasis at a vascular suture line, and in preventing visceral leaks from enteric organs such as the gut or lung. It can also be used for adhesion prevention. Advantages: it contains no human or animal products. It does work independently of the clotting cascade. Disadvantages, however, it must be applied to a dry field, and it does become somewhat opaque after application, which limits visualization of the underlying tissue and structures. It also swells and reaches about 4 times its normal volume in about 24 hours. To compare these 3 products made by Baxter, you can see the FloSeal is the most hemostatic but has the least sealing properties. TISSEAL is a moderate hemostat but has high sealing properties, and CoSeal is a low hemostatic product but is a good sealant. The formaldehyde or glutaraldehyde tissue adhesive glues are another group of products. In Europe, a gelatin, resorcinol, and formalin glue is available. This is a formaldehyde-based product, and it's used in Europe for aortic dissection repair and as an adjunct for vascular anastomosis. In the United States, we have BioGlue, made by the CryoLife Corporation. It's a glutaraldehyde and albumin-based product, and it's FDA approved for type A aortic dissection repair. BioGlue is used for large vessel repair, particularly for thoracic aneurysms, and has 2 components. One syringe contains bovine albumin, the other contains glutaraldehyde. When these polymerize together in the needle tip, which is a mixing type of tip, it forms a hard, strong seal, and it sets up very quickly. There are some off-label uses, and these uses are also seen outside the United States, in Canada and Europe, where these are also used for soft tissue repair, such as cardiac, genitourinary, or dural repair, in the GI tract, also with pancreas and spleen, and also for hepatic, biliary, and pulmonary injuries. It's also used as a fixation for surgical meshes during hernia repair. BioGlue has some advantages in that it's very easy to use and assemble. It comes ready to use from the package and only requires a syringe to be assembled. It is resorbable, although slowly. It does work independently of the clotting cascade and is not removed by fibrinolysis. It does provide superior adhesive strength, being the strongest of the glues I've described today, and can be used as a sealant, an adhesive, or a tissue reinforcer. Its hemostatic capability, however, is not good. Disadvantages: it does take some skill to apply. It does contain glutaraldehyde, which does cause fixation of tissue. It does have a potential risk of infectious disease transmission because of the presence of the bovine serum albumin, and it must be applied to a dry field. Papers using the product in clinical scenarios It has been shown to be effective in sealing lung lacerations, preventing air leaks, and sealing bronchopulmonary fistulas in thoracic surgery. And it has been used in neurosurgery to repair the floor of the sella without causing CSF leaks during transsphenoidal pituitary surgery. Trauma papers are very limited. So far, a paper describing its use to prevent splenectomy during incidental splenic injury for laparoscopic nephrectomy has been described. Complications, most of these are described in the vascular and cardiothoracic literature and usually occur with embolization of hard fragments of the glue, either ending the circulation and embolizing, interfering with valves, or causing other injury to adjacent structures. Other complications, in a recent paper looking at dural repair, it was reported in the journal Neurosurgery in 2007 that in pediatric craniotomy there was an increased wound complication rate. This was thought possibly due to the intense inflammatory reaction that is sometimes seen when BioGlue is used. BioGlue comes ready to go with a syringe that has both the albumin and glutaraldehyde preloaded. The syringe and mixing tip are simply assembled and it is ready for use. A new product which is being investigated by the CryoLife Corporation is BioFoam, which is a foaming version of BioGlue which expands to 4 times the original size and may have some hemostatic product but is not ready for clinical release. Looking at the product costs, all these agents are somewhat expensive and will cost anywhere between $117 to $795 depending on the volume of product used. In summary, there are many products. They all differ in their ease of use, their efficacy, and their safety. There is a need to train surgeons and residents in these products in a safe fashion before they're widely employed. There are many new products in the pipeline, and each of these will have to be carefully evaluated by surgeons before adoption. Thank you.